Hey everyone, welcome. You are entering the Silver Hill Hospital Grand Rounds program. We'll get started in just a moment as people settle into their Zoom boxes. All right, welcome everybody. I'm Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital. And as always, we are absolutely delighted to have you join us and are privileged to welcome together Dr. Joseph Goldberg, who will be presenting on the topic Understanding Pharmacologic Management of Treatment Refractory Mood Disorders. And I'll have the pleasure of introducing him in just a moment. First, some little housekeeping. Our next grand rounds will take place on February 26th with Dr. John Allen, who will talk to us on the topic of bringing psychotherapy back to life. So that will be a don't miss it kind of grand round. So hope to see you all there and bring a friend. So back to today's lecture. Your questions remain an important part of our grand rounds as always, and I will moderate a Q&A discussion with Dr. Goldberg at the end of his lecture. It's a great opportunity to put forward questions and comments to Dr. Goldberg, which you can submit anytime during the lecture by using the Q&A link. And feel free to put in questions anytime during the talk. We'll get to as many as we can. If you would like CME or CEU credit today, please complete the evaluation survey that will automatically show in your browser when we end the webinar. And we'll also email a copy of the survey to today's participants. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest, and Dr. Goldberg will show a slide with his disclosures. It now is really a great pleasure and honor to introduce our guest speaker today, Dr. Joseph Goldberg. And just to let you all know, when I was coming to Silver Hill, I don't know how many people around the country that I knew said, "Oh, you got to meet Joe Goldberg," and it's just been an honor to get to spend a little time. So Dr. Joseph Goldberg is a clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai and president of the American Society of Clinical Psychopharmacology. Back in the day, he ran main house here at Silver Hill Hospital. And now he serves as the deputy editor in chief of the Journal of Clinical Psychiatry and is an associate editor for the journal CNS Spectrums. He attended college at the University of Chicago, graduate school in neuroscience at the University of Illinois in Chicago, and medical school at Northwestern University Medical School, and completed a psychiatry training and psychopharmacology research fellowship at the Payne Whitney Clinic of New York Presbyterian Hospital. His research is focused on the clinical phenomenology, treatment, and outcome of mood disorders. He's published over 240 peer-reviewed papers on psychopharmacology and mood disorders, as well as 5 books, most recently Clinical Reasoning and Decision-Making in Psychiatry, published in 2024 by Cambridge University Press. Dr. Goldberg is a distinguished life fellow of the American Psychiatric Association and has been listed for many years in Best Doctors in America and Castle Connolly's America's Top Doctors. As I mentioned, he's the president of the American Society for Clinical Psychopharmacology, ASCP, and really they welcome new members and participants to their many educational programs, and I'm sure he'll let you know that as well. So wow, it is just really, Dr. Goldberg, our great fortune that you said yes to our invitation to talk to us today. So thank you. Thank you for being back here, even virtually to Silver Hill, and great to see you.
Well, thank you, Jeff, for the very kind and narcissistically gratifying introduction. And it is nice to be back. I feel as if I'm back. I think I was at Main House, gosh, before the renovation, so maybe 20 some odd years ago. And part of the time when I was at Silver Hill was really trying to set up a mood disorders program. That's really been my interest for many years, as Jeff mentioned, largely in psychopharmacology, and ancillary areas, course and outcome, comorbidities, complexities. We actually published a few papers off a Silver Hill database looking at diagnostic validity and comorbidity and what do you do with hard to treat patients who have mood symptoms and substance use symptoms. So some of what I'll be talking about today actually uh, beckons back to the Silver Hill days. So I'm hoping what I'll be sharing with you will be informative, clinically useful, pragmatic, and above all else, engaging and fun to listen to. I try to make things lively. Those of you who know me, so I try to not lose anybody on the Zoom format here. So here's my disclosure. I've been a consultant to a number of pharmaceutical and industry organizations and pharmacogenetics and others, and have been on the Speakers Bureau for a few organizations. Some of the things I may talk about today will go into the realm of off-label treatment, and I'll signal that as it comes along. So here are our, modest goals for the next hour or so. By the time we're done, we will have shared expertise in identifying the features and clinical correlates of treatment refractory mood disorders. I'll define that in a moment. Summarize criteria that can help determine when to switch or when to augment. That is, um, when to cut bait, when to play them or trade them. How do you make decisions? The book that Jeff mentioned that I just published with Steve Stahl really talks a lot about decision making in psychiatry. And so I want to say a few things about how do we decide, am I going to make a change? Am I going to augment, so that it doesn't feel like an arbitrary kind of saying, here's my patient with ongoing symptoms, what should I do? There's actually some guidelines here. And then lastly, how to recognize and select evidence-based combination pharmacologies for patients with hard to treat forms of major mood disorders. So sometimes we put together clever combinations that are pharmacodynamically synergistic and clever and elegant, and other times they're a little more happenstance. So I'll try to speak to some of those things as well. So language, treatment resistance, treatment resistant depression is a term that's been used quite a bit. There's a paper that Roger McIntyre in Toronto and I just published last year, kind of talking about the variability in, well, our language. So TRD isn't a formal term. It's not like the FDA or the NIH or anybody uses the term. Even DSM-5 doesn't have that as a category. There's different variations. If someone is doing a clinical trial with a new intervention for depression that hasn't gotten better with other things, and here I'm designing my trial and I want to go to the FDA and get an approval, usually TRD in the eyes of the FDA studies means you've taken at least two things that were appropriate and adequate trials. That means a long enough duration with an adequate dose and not shown a response. And we're going to define response in mood disorders as you're at least 50% better than when you started out, which is not the same thing as remission. Remission means your level of symptoms is so low at the end of the day as to be not that clinically meaningful. So response in some ways is kind of a low bar. You could start out, if you're doing measurement-based care, say a PHQ-9 score that we often use of say 24, and wind up with a 12. And so you're a responder, but you're still moderately depressed. So it's sort of a starting point, response. Some interventions make a more rigorous definition. To get vagus nerve stimulation, you've had to be a non-responder, or deep brain stimulation. More invasive procedures, you've had 4 non-responses to adequate trials of things. Some researchers use just the definition of one thing that doesn't work. But for practical purposes, we're going to be talking about a number of things that haven't worked. So we'll go on with that as we proceed. It's about a third of people with unipolar major depression who haven't gotten better with, let's say, 2 or more appropriate interventions. And by way of, I guess, nomenclature, John Rush used the phrase difficult to treat as an alternative designation for treatment resistant. Kind of connotes a similar concept. I think is partly meant to sustain a sense of hopefulness. Who wants to be told you have treatment resistant anything or treatment refractory anything? So difficult to treat implies, well, the stakes are a bit different. And we're going to talk about this quite a bit from a practical standpoint. said differently, patient comes to you, they're symptomatic, they've been on other things, and you've got the universe of over 3 dozen monoaminergic antidepressants, atypical antipsychotics, so-called mood stabilizing drugs, novel therapeutics. If someone's in the difficult to treat realm, that pharmacopoeia narrows considerably. My private practice these days is almost exclusively second opinions. And so I do this day in and day out, is not just sort of scouring the pharmacopoeia for what haven't you tried before? Oh, you haven't taken paroxetine. Oh, you haven't tried fluvoxamine. Oh, you haven't taken desvenlafaxine. So one could do that, but it becomes very arbitrary if after a few non-responses have occurred. The first point I'd like to impart to you is that that's really important information. If you're in this roughly 1/3 of mood disorder patients, and it's not that different for bipolar statistically as unipolar, about a third where at least a couple of things haven't worked, rather than arbitrarily go through blah, 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 you want to more confine your attention to the smaller universe of things that have been studied when other things don't work. So all these things are encapsulated in the difficult to treat concept. As you can read here, it's not just the non-response to multiple interventions, but the functional impairment, the symptom severity, the potential for chronicity. More begets more, the new normal. When the longer you've been ill, your baseline changes. We talk about this with patients, or at least among ourselves all the time, is this their new baseline? And we try to prevent that from happening. It's one of the reasons why you don't like to see persistence of psychopathology go on and on and on, because persistent psychopathology is like relatives that come to visit and then they won't leave, and they're harder to shoo out the door after they've been there long enough. So a goal is to choose appropriate treatments for the appropriate diagnosis, and then pick things that we know are likely to be meaningfully impactful more as we go. I want to introduce you to the term, if you don't already use it, moderators. Moderators are baseline characteristics about a patient that inform outcomes. So rather than say, hey, I have a patient with depression that's tough to treat, can you see them? Sure, but that's like saying I have a patient with high blood pressure, or I have a patient with lung disease, or I have a patient with cancer, without refining the description more. So these this listing of characteristics, baseline features that will influence outcome, are almost the bread and butter of making choices for what am I going to do next. So to tell me this is somebody with hard to treat depression is okay, but if you tell me so their PHQ-9 score is over 22, they've had their current episode for longer than a certain amount of time, little pearl. In the world of bipolar disorder, long-term follow-up studies say that the average duration of illness of an episode is 14 weeks. The NIMH collaborative study showed this some years ago, multi-decade follow-up study. So I always want to ask a patient, say with bipolar disorder, when did this begin? Not just because that's a nice question that we're all taught to ask, but I kind of want to know where they fit into that 14-week mark. If someone says to me, well, as a matter of fact, my depression began 12 weeks ago, 2 weeks from now, how do I know if my intervention might account for their improvement or just the natural course of their illness? So that's one moderator that comes into play. Somebody with rapid cycling who's having 4 or more episodes per year, and an episode has to have a certain duration, and then there's got to be separation from the next episode. So duration features, how long has this been going on, and spacing of episodes in the last year is actually a really important moderator that can inform what you're going to do, because there's one patient who's been manic for about 5 months now and not getting better with various things, and we're talking about ECT, and I mentioned to the patient and the family, the natural course of this is such that it ought to run its course at some point soon. So if the person gets better with whatever you give them, you just want to bear that in mind. If you're going to have a mood disorder, have it as late in life as possible, because early onset is unfortunately probably one of the biggest predictors of poor response to all kinds of things. Delayed time to getting a treatment started can be a factor. I'll say more about that in just a sec. Concurrent anxiety disorders or symptoms is notoriously one of the things that says to us, ooh, your depression is going to be harder to treat. In the STAR-D study, the sequence treatment alternatives to relieve depression, I don't remember if anxiety was the biggest predictor of non-response, but it was certainly high up there. So anxious depression, I'm sure I'm telling you nothing you don't know clinically. Anxious depression is just harder to treat than non-anxious depression. Oh, as I learned in my days at Silver Hill and elsewhere, you're allowed to have a mood disorder and a personality disorder, and the two don't go very well together. In fact, even some randomized trials say that if you happen to have, say, major depressive disorder and comorbid borderline personality disorder, response to ECT is poorer for your depression than if you don't have the comorbidity of borderline personality disorders. So, hoping that if I treat the dickens out of your mood disorder, your comorbidity will go away doesn't necessarily play out. And to not address the comorbidity may actually, well, make it all the more difficult to treat the mood disorder. Um, Comorbidities in the world of substance use disorders don't need me to tell you about their impact. Um, Number of non-responses to an adequate trial in the current episode, big predictor. More on that in a bit. Poor adherence, high inflammatory markers. Some studies say we don't routinely go around measuring CRPs because they're not really shown to be practically translatable, but in research studies, they have some value. So you kind of put all these things together, and then you can come up with a more refined description of what's going on with the patient. Let's not conflate real treatment resistance or difficult to treat hood with pseudo treatment resistance. That is to say, oh, I took this SSRI for 2 days and I got a headache, so I stopped. Or I filled the prescription, I looked at it, but I didn't want to take it. Or yes, I took 25 milligrams of sertraline for 6 months and I'm no better, so I stopped it. You get the idea. So an adequate dose, an adequate duration, not to mention an appropriate treatment. So, oh, I've been taking my alprazolam for my depression and I'm still depressed. Or I have bipolar disorder with mixed features and I'm taking an SSRI and I'm still symptomatic. I mean, the wrong treatment for the wrong ailment is not treatment resistance. Intolerances. Oh, how often I've seen people with purported TRD or difficult to treat depression who come in with a long, lengthy list of I've taken this and this and this and this. And it turns out everything got stopped within a day or two or three of starting, or some adverse experience either precluded their taking the drug for an adequate duration or getting the dose high enough. Every now and then I can say to someone, someone told you have treatment resistant depression. You actually haven't had an adequate trial of anything. It's as if you're untreated. And some people draw actually some sense of comfort, not to mention chagrin sometimes in being told that. Like, what do you mean I haven't been treated? Well, everything you've taken never really got to an adequate dose. Imagine if you were taking an antibiotic for strep throat, you took half the dose for 2 days and you stopped. And then you get a super infection. And that's not treatment resistance. That's artifact of the treatment itself. Or things get missed. My friend Tony Rothschild at UMass likes to say that in his domain, sometimes half of the patients he sees with treatment resistant depression have unrecognized psychosis, and it may not be as obvious as you might think. It might even be something like delusions of hopelessness or worthlessness, which if you don't probe the belief, conviction, and intensity of, you may just sort of shrug and say, okay, low self-esteem, without appreciating, no, this is actually an ingrained belief, and to not address it unto itself, for psychotic depression, an antidepressant is not going to work. Also, wrong diagnoses. Bipolar depression. When it comes to antidepressants, this has been one big focus in my own research. Many people seem to have the presumption that the big deal with antidepressants and bipolar disorder is that they make you manic, which is more urban legend. The best of meta-analyses say it's about 10 to 12% of true blue bipolar 1 patients for whom an antidepressant might make them manic. So it's a minority. The bigger risk with antidepressants is they've never been shown to work in bipolar depression. It's like using antibiotics for a virus. So if someone comes to me with TRD and they've been on all the antidepressants in the world, and we do a screen for bipolar disorder and take a family history and determine there's actually a pretty good clinical basis for making a diagnosis of bipolar disorder, again, I'll say it's as if you've never been treated. You've been taking medicines that haven't been shown to work for this ailment. I've never, ever, ever, ever met somebody with active alcohol or substance use disorders with a mood disorder who gets better from their mood disorder while they are still actively using. And I didn't just learn that at Silver Hill, although that's certainly, I think, rung true. But I will tell patients, look, if you want to make inroads in your mood, we need to get rid of the contaminants. Alcohol is a neurotoxin. One big alcohol binge blows away 25,000 neurons. You need all the ones you can get. Um, Alcohol is a CNS depressant. Psychoactive substances are mood dysregulators. So you're wasting your time with psychopharmacology for mood if you're still actively using. And that's not a message people always want to hear. And it's not an easy message to deliver, but more than a few times in my career, that's been what I would tell patients as the reality. So let's get you sober and then we can more properly address your mood. Medical etiologies. Once had a patient with treatment-resistant depression whose TSH came back at 71. So there's one treatment for that depression. It's called levothyroxine, and all the antidepressants in the world aren't going to help that otherwise. Also like to mention here, negative symptoms in depression. So depression is a very positive symptom. It's a feelingful state. I feel awful. I feel anguish. I feel pain. I feel wretched. I feel. Whereas in negative symptoms, more often associated with schizophrenia, type 2 schizophrenia, I don't feel anything. It's not even just anhedonia. It's kind of an absence of emotion. I don't feel hopeless. I don't feel sad. It's kind of like a flat deficit state. And antidepressants don't work so well. In fact, nothing is terrific for negative symptoms, but when we come to revisiting diagnostic questions, that's always, I think, one that we sometimes miss. So, duration of untreated illness, DUI. Well, that's a known moderator throughout medicine. The longer you have a malignancy or an infection, the harder it's going to be to treat, obviously. In the world of mood disorders, especially with current mood disorders, it's been at least proposed that persistence of mood symptoms may have a behaviorally sensitizing effect on the brain or a kindling effect or an evocative effect to trigger more potential relapses or just be harder to treat. Now, I said a few minutes ago that there's a natural course of things. Bipolar episodes on average run 14 weeks, unipolar major depressions on average run under 12 weeks. But about 1 in 5 people with either bipolar or unipolar disorder will have persistent mood symptoms for up to 2 years. If you go that long without getting treated, it probably leaves a mark. It certainly doesn't help your psychosocial functioning. You don't finish your education. You don't negotiate your developmental milestones. It's harder to maintain a job. You go on disability. They can't take you back. You can't go back. And so we get this sort of downhill spiral, not to mention the potential accrual of comorbidities. So there's a bit of a mixed literature on whether people with a longer duration of untreated illness are just harder to treat or unresponsive to treat. And this nice analysis points out that, one confound here is, well, is this your first rodeo or your second or your third? The number of episodes may confound this. So my duration of untreated illness may have been, I've had 3 depressions, all untreated, and now I show up on your doorstep as opposed to I've had 1 depression. And back to this notion of more begets more, on off patterns, the notion of kindling or behavioral sensitization is a sort of an interesting confounder. It's to suggest the more times your brain experiences an event, the more that may provoke the potential for just hard to treat outcomes over the course of time. For practical purposes, look, they're both difficult. Someone who's had many episodes that haven't been treated, or someone just a long duration of illness, it is harder to treat, but certainly not impossible. But when you're going like this and saying, how can we not getting better? These would be some of the moderators to think about. The other variable that's relevant here that I mentioned in this box is the number of failed trials in the current episode. I'm going to say more about that in just a moment. Um, well, here's a moment. So, in the case of this is in bipolar disorder. So, this is just a nice review that was suggesting, yeah, if bipolar disorder goes on untreated long enough, it is just harder to treat. And even medicines like lithium, as we sometimes think of as the gold standard, have kind of a narrow therapeutic, well, impact, not just index. Meaning, lithium works much better in your first or second or third episode. It doesn't work as well after that. Which is to say that if you're seeing a first episode manic patient, you'd have to sort of actively decide why you're not going to use lithium. Because as I sometimes say to patients, you'll never again have your first mania, and it's a window of opportunity. So there's actually fairly robust data that lithium is responsiveness is very sensitized to the number of episodes. One theory as to why some anticonvulsants like valproate or carbamazepine may be more robust in multi-episode patients is this kindling notion. So there are studies that say people that have had more than 7 or 8 episodes and they're manic, valproate beats the pants off lithium just on that variable alone. So in the spirit of hard to treat, we've got duration of untreated illness, number of episodes you've had altogether, number of trials in the current episode, and just where you are in your lifetime trajectory. You've probably seen this slide before. This is from that STAR-D, Sequence Treatment Alternatives to Relieve Depression study. So they gave you 4 bites at the apple in this study. Most of you, I'm sure, know this clinical trial. It's pretty famous. Everybody got citalopram the first go around, and the odds of success were 37%. And if that didn't work, you had a range of things to try next. And if you went to the second round, now your success rate remission went down to 30%. And if that didn't work, more fancy things came down the road. And look at these remission rates, 13%. You had 2 bites at the apple. We didn't go past stage 4 in STAR-D. So this doesn't mean, I'm sorry, sir, you have an untreatable condition, and maybe we'll call it difficult to treat, to maintain a sense of hope. But this is a gigantic drop down. I mean, to say to yourself, probabilistically, there's like a 1 in 10 chance of a success after 2 non-responses means a few things. One, make these 2 counts, right? Save the bullets for the tigers. So don't skimp. Your first and second shot at depression is fundamentally important, not just because it makes intuitive sense, but once you get to here, it just gets harder and harder. And in STAR-D, this is kind of depressing. No matter what you got as the next step, didn't matter. This is arguably one of the biggest depressing findings from STAR-D. If I gave you bupropion or CBT or sertraline or switched to an SNRI, it didn't matter. The response rates were all about the same and all kind of meager, which is another way of saying once 2 things have gone by, reshuffling the same old deck of, let's call them non-distinguished options, interventions that have not been shown to work when other things haven't, you will go in circles, round and round and round with this 30% response rate as episode marches by. So after 2 or 3 episodes, hey, how about venlafaxine? How about bupropion? Yeah, how about something that's been shown to work when multiple other things don't? So I mentioned one of the things I want to talk about is switch versus augment. I love this paper by Sid Kennedy. I make my residents read it. It was a nice summary from CANMAT guidelines, sort of outlines some rules of the road. So let me briefly summarize these. So you have major depression, you're not getting better, and one thing hasn't worked, and only one thing. Go ahead and switch, as opposed to multiple things haven't worked. Now, as I've said, the universe of viable options is shrinking. So you can make something out of something. If you've got anything to work with, don't be stingy. It's not like, oh, we've got zillions of things. Remember STAR-D, slide before, 2 non-remissions, 13% chance of success. So I'll take whatever I can get. And that also means we may have to negotiate a bit about tolerability for side effects. So someone who's been through the ringer with multiple things and you're proposing perhaps higher level interventions, maybe ketamine or MAO inhibitors or tricyclic antidepressants or things that are potentially more burdensome, olanzapine fluoxetine combination. Uh, yeah, risk benefit wise, these are examples of things that can work when other things don't, but some of these have more side effects. And so we don't have the same luxury as somebody who's just had one non-response. I took my one treatment and didn't like side effects. Okay, you've had either one treatment or tolerability is a deal breaker. Fine, switch to something else. Whereas if the initial antidepressant was all tolerated and side effects are not a problem, might want to augment. I love row 3 because it's got a lot of statistical value. Response, remember, I defined, is you're at least 50% better than when you started. Please use measurement based care when you're treating hard to treat forms of mood disorders. So use a rating scale. PHQ-9 is very popular for depression. It's patient self administered. We don't have a great rating scale for mania symptoms that's patient administered. We still use clinician scales like the Young Mania scale. But the point here being, if you're more than 50% better, we're in the clear. We got something to go with. If you're less than 50% better, this is important, but at least 25% better, this is actually a statistically very relevant mediator. A mediator is a predictor variable after the treatment has started. If you're not at least 25% better, you don't even have a partial response, cut bait. You will go nowhere. So that means if my pH goes from a 20 to a 17, that's not a 25% improvement. I need a 16 or better. I know this may sound picky, but it actually works. So you really need a 25% reduction to justify keeping someone on something. If you haven't seen 25%, cut bait, the odds of success are pretty low. If you get a 25%, you can work with that. Less severe symptoms and the stakes aren't quite as high, go ahead and switch. More severe symptoms, we'll take whatever we can get. Hang on to whatever you've got. And patient preference obviously counts, but again, depends on how much we have to work with. So sometimes we say, well, let's use broader spectrum drugs. And my colleague, George Papakostas, who's on the board of directors at the ASCP, he's a Mass General, published a really nice review paper some years ago that said, if you look at the impactfulness of these various treatments, two things. Their confidence intervals overlap, which means that even if you were going to say, the magnitude of improvement with duloxetine looks like it's bigger than fluoxetine, that's not really true, because if the confidence intervals overlap, it's not a clinically meaningful difference. Again, there are not gigantic differences among these compounds. And if we say, all right, you didn't get better with an SSRI, let's give you an SNRI, venlafaxine, desvenlafaxine, duloxetine, levonornazepam. Those are the 4 that we use. You might think, bet you're going to get a lot better with a broader spectrum drug, right? Right? Well, not that much. I mean, a little bit. Response rates with an SNRI in his meta-analysis were 64% compared to 59% with an SSRI. It's statistically significant, but the probability of an SNRI working when an SSRI doesn't is 6.3%. 6.3. That's right over here. Said differently, you've got to treat 24 people with an SNRI if they didn't get better with an SSRI before someone's going to get better. That's not very good numbers. Does that mean don't go there? Well, this goes into your clinical decision making. This ain't no magic silver bullet. So you didn't get better with an SSRI, we'll use an SNRI. 24 people are going to have to get that happen to them before you're going to see a success. So yeah, I mean, it's a nominal step. There's better things, which I promise we'll talk about. Okay. Oh, here's another depressing paper, which says if you line up all these antidepressants and ask what's the most effective, here are the odds ratios of seeing a response. So you could look at this and say, wow, I'm going to give everybody amitriptyline. It's got the biggest odds ratio. You're more than twice as likely to become a responder with amitriptyline than placebo. And I'm never going to give you desvenlafaxine or roboxetine's a drug the FDA didn't even approve in the US because it's got the lowest odds ratio. I guess you could say that, but again, these confidence intervals overlap, which means there's really not a far and away difference. They all work. If you want to say amitriptyline is the Empire State Building and sertraline is the Chrysler Building, yeah, it's taller, but it's not a drastic difference. So when we talk about breadth of spectrum, I want to encourage you to think, don't get overly enamored of this concept, at least not with monoaminergic drugs. These are all medicines that tweak norepinephrine, serotonin, dopamine for the most part. So we'll talk more about novel things like glutamate and ketamine and so on. Um, uh, but it's kind of reshuffling the deck. So if you don't get better with one or two, knock yourself out. Try them all. How many you got here? 1, 2, 3, 4, 5, 7, 10. You got 20 things to try. The natural course of illness alone, you're probably going to get better at some point. But before you say, wow, five's a charm, I finally gave you S-citalopram and you're better after 7 prior trials is probably random noise. So you'd think antidepressants are potent. Whoops, are potent, right? At least these guys think so. Of course, you feel great. These things are loaded with antidepressants. Well, for the 38% of people that get better on the first go around, now it's true. After you got to, I think, the fourth phase in STAR D, about 70% of people finally got better with something. But wow, 4 trials, and how much of that was just the natural course of illness? So these are not gangbuster drugs. Don't believe me? Here was a paper in New England Journal of Medicine looking at the effect sizes of antidepressants in published studies and non-published studies. So an effect size is a decimal. The bigger, the better. A large effect size is 0.8. That would be like ECT in depression, big effect size. IV ketamine in depression, big effect size. Um, 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 Amphetamines and ADHD, big effect size. Medium effect size around 0.5. And less than that is small to medium. And as you can see, the published effect sizes of all these antidepressants is like small to medium. And if you look at the unpublished studies, which these rascals in New England Journal did, they are piddly. Nobody publishes the wimpy studies. These folks went out and looked for them. So effect sizes under 0.2 are considered microscopic. Does that mean never give anyone citalopram or venlafaxine? No. These are probabilistic studies. That means based on groups of people, doesn't necessarily translate to your patient specifically, but it does mean there's nothing leaps and bounds better with any one of these drugs compared to another. On top of that, we have to contend with the placebo response. So here's a real conundrum. We're talking about hard to treat, difficult to treat, treatment resistant forms of mood disorders where lots of things don't work. And yet, a third of people get better with a placebo, 30 to 40%, even in bipolar depression, which some people would say is very hard to treat. The pooled placebo response rate, when people have studied this, is 39%. Wow, how can that be? Well, it's a few things. For one, placebo is not no treatment. And these effect sizes are comparing drug to placebo. When you do a clinical trial, you can't do accidental psychotherapy. You can't say things to the patient in a drug study like, that must be very hard for you, and how are you managing? Next question. So no supportive comments. There's actually manuals that will say, you have to limit the amount of time with the patient. The goal is not to be inhuman and rude, but you introduce additional elements that can impact mood outcome. Secondly, just imposing the structure of a study where you're asking patients questions and you're seeing them every week and you've screened them is not no treatment. So in fairness, an effect size means above and beyond the non-specific things that you do. So some would call that accidental supportive psychotherapy. And well, that's 30, 40% response rate. Placebo effects don't last, though. And that's another element in hard to treat mood disorders that I would encourage you to be thinking about is a real response sticks around. So do you ever see a patient who comes to you and they say, oh, I took such and such medicine and I got better, but then I relapsed after 5 days with my mood? Well, you can't really judge response in only 5 days. In fact, DSM actually says you've got to hold on to your response. Get this, 8 weeks of sustained wellness defines remission. It's not just you're better on Wednesday and that's it. So it's hard to sustain a response. And if someone has a fleeting response, we often wonder if that's just a proxy for the placebo effect. So this is an irony. If you're a clinical trialist, you're doing everything in your power to minimize the placebo effect. And if you're a clinical practitioner, whether you realize this or not, you're doing everything in your power to maximize the placebo effect. And this is what I think makes for a very interesting blend of psychopharmacology and, let's say, psychotherapeutic acumen or therapeutic alliance, because therapeutic alliance really does contribute. Last point here, there was a famous study by this guy named Walter Brown out at Harvard where he gave people an open trial of placebo for major depression. Here, I'm giving you this pill. The language he said was, there's no active medicine in this, but some people have found this to be helpful. Well, that is a true statement. Want to guess the response rate? You have to take this pill every day. You come meet with me once a week. We're going to meet for whatever the time frame is. I'm going to ask you questions. How's your sleep, your energy, your concentration, appetite, etc. Any side effects, blah, 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 blah. 70% of people were responders to open label placebo. They knew they were getting, well, something that doesn't have active medicine in it. Think about that. Discouraging data on antidepressants. Well, we're going a little meta beyond just the pharmacology, but let's press on. So again, here, just sort of recap some of the things you want to think about. I'm kind of elaborating a bit more on those CanMat Sid Kennedy comments about switch versus augment. So pay attention to the number of failed trials in the current episode. If you haven't got a lot of other options, that's a narrower range of options. Are there viable options? Someone is getting better with ECT or an MAOI or ketamine. Got anything else like it? No. Think about clozapine in schizophrenia. Got anything else like it? No. I mean, some treatments are unique, and count your lucky stars if you're a responder. I once had a patient when I was at Silver Hill in Main House who had made a very serious suicide attempt, gunshot to the head, missed. Bullet went, this is a true story. Bullet went to the wall in the next apartment. They called the police. He was brought to Silver Hill, got ECT, sort of got better. I was seeing him afterwards. They put him on an MAO inhibitor. He got much better, dramatically better. And many, many things hadn't worked. And there came a point where he was euthymic and said, I really don't like the sexual side effects of this. Can I stop it? And I found myself having to really sort of hold back emotions, saying, well, you can imagine what I was thinking. You're lucky to be alive. You have a lethal illness and you literally dodged the bullet. And we found this thing that works. And I can appreciate side effects as problematic. I'm very sympathetic, but oh my God. I mean, no, I don't have anything like an MAOI. I don't. And he was actually very adamant, and he ended up leaving treatment, and I actually don't know what happened to him. So yeah, this is back to the therapeutic alliance. How do you engage someone when you say in so many words, you have a life-saving remedy here, and do I have alternatives or not? Tolerability. So some adverse effects are bothersome and some are dangerous. We need to know the difference when we're making decisions about whether to retain or not. Unique symptoms. We might retain a medicine in a regimen because it's got a particular target symptom. You might be giving a certain drug for its anxiolytic effects or its soporific sleep inducing effects, or perhaps lithium for suicidal behavior or impulse control. As long as you can name the job description of each component in the pharmacology regimen, I'd say you're on evidence-based grounds. Even if you're not getting the totality of improvement, your PHQ is still up there, but let's retain this component because it's having this beneficial effect. I tell patients, let's think of your medicines like employees. And from time to time, we will do a performance review and make sure that every component in the regimen is earning its keep. Being mindful of comorbidities and timing of when to make a change all has to sort of go into our calculus. As I said a bit earlier, anxiety is one of the biggest predictors of poor response in the world of major depression. Did you know this study by Michael Face with vilazodone for major depressive disorder Why is this an important study? It's because vilazodone had greater efficacy in anxious depression than non-anxious depression. And to my combing of literature, nothing else does that. If I have major depression with anxiety, um, nothing works as well compared to having major depression without anxiety. Not only did vilazodone work, but it worked even better in anxious depression. We could speculate, is that because it's got a potent 5-HT1A partial agonism? That is to say, it's kind of like buspirone on steroids. It binds to the same receptor as buspirone, 5-HT1A, but does so with a much greater binding affinity. That's one theory about vilazodone. It's got other targets as well. I'm not saying it's the be all and end all, but anxious depression, one needs to sort of know about this study because, as I say, you have anxious depression, just going to be harder to treat. Can we try other things? Of course. But this would be an example of a moderator that would inform your treatment choice. Um, Here's another tidbit, early improvements. So how long till this kicks in? Here's a lovely statistic. The 2-week, 20% rule in treating major depression. And there's analogous data in bipolar disorder. There's also similar data in schizophrenia. By 2 weeks, you should see a 20% improvement on whatever measure you're using. That means if my PHQ score goes from a 20 to a 16, that's a 20% improvement, I think, right? The probability that you're going to be a responder by the time we're done is about 8 to 9 times higher than if I don't see that. So it's got really good sensitivity. I misspelled that. It doesn't have perfect specificity, which means that all is not lost. If you haven't seen a 20% improvement by 2 weeks, doesn't mean you won't, but it's an early marker. So what does this mean? Well, at 2 weeks, if you're 20% better, you'd say to the patient, we're exactly where you want to be. You're right on the growth curve where you want to be. You don't have to change anything. Just hold that pose. And if you haven't seen a 20% improvement by 2 weeks, do something. Anything. Raise the dose, augment, add a psychotherapy, increase the frequency of visits, double down on the substance use treatment, something. If you do nothing, like I say, you're 8 to 9 times less likely to see a response. This is a great meta-analysis, required reading for my residents, 15,000 patients. So the 2-week rule for major depression counts. Now, in very hard to treat depression, this is your 4th or 5th treatment in this episode, things may be different. So this is not exactly as translatable to difficult to treat or hard to treat depression, but it's not a bad rule of thumb. Hey, how about just raising the dose, right? Some is good, more is better. You'd think, right? Well, here's a meta-analysis on the left, which looks at the effect sizes. That's that decimal I told you about before. The bigger is better. 0.8 is a large effect. 0.5 is a medium effect. 0.2 is a small effect. And under 0.2 is microscopic. Line up all the studies that said we're going to crank your dose way, way high. Piddly effects. The odds of a response are not different from keeping the dose where it was before, and you're no better than placebo. And here's another specific example: desvenlafaxine. If some is good, more is better, right? Actually, no, not as a rule of thumb. The change in depression symptoms with desvenlafaxine, major depression. This is from package insert: 50, 100, 200. There was no difference. Now, this is probabilistic. Again, this is based on studies of groups of people. Your own patient might do better. It's just you can't generalize from literature and say, well, Mr. Jones, you've been on desvenlafaxine 50 milligrams. You didn't have a 20% improvement at week 2. So let's bump it to 100. I can't tell you with an evidence base, and that's likely going to help. So what should I do at that point? That's a really good question. Got to think about that one. You might go to 100 if there hasn't been a 20% improvement. You might switch depending on, well, is this his 2nd, 3rd, 4th treatment in this episode? You might add a psychotherapy, you might increase the frequency of visits, etc. But don't bank on a remedy here. Maybe you can fine tune a partial response at the higher doses. Maybe you can recapture a lost response with higher doses, but don't automatically assume higher doses will do more for you. unless you're targeting something else, OCD, maybe higher doses work. But anyway, you get the idea. Just a word on pharmacogenetics. I've actually been involved in some of this work. So, round up a group of TRD patients and do pharmacogenetic testing on them and ask, do their symptoms of depression get better if their treatment is guided by the protocol or not? And the answer is no. This was the largest study ever done, randomized trial in pharmacogenetics. Didn't make a difference. But then, as researchers do, they kind of tortured their data and looked at other outcomes. They said, well, response rates were higher and remission rates were higher. It's a problem, though. This was their main study. And if your main study doesn't work, you can't go back later and say, well, it did work in left-handed people, or it did work in Democrats, but not Republicans. Those are hypotheses. Maybe, but on the whole, the study didn't work. And even more importantly, look at this. Your chance of remission with treatment as usual was 10%. This was a tough population. Add on pharmacogenetics, it goes up another 5%. You'd have to do testing on 19 people before you're going to get one additional response. So pharmacogenetic testing has its place, but not in predicting response. It's got far more data in looking at tolerability issues, being able to convert a prodrug to its active metabolite, safety issues, drugs that are 2D6 substrates that might prolong the QT interval, like iloperidone or risperidone, or drugs that have to convert from a prodrug to an active drug relevant, but that doesn't really help us predict what's going to work. So hence the FDA issued this consumer warning a few years ago. Basically, caveat emptor, do not tell patients that this is a test that's going to tell you what's going to work for you. It's still experimental in terms of efficacy. It may have some value for safety and tolerability. So now, number of non-responses in the current episode. Here's a really depressing study from Mass General where they tallied up how many non-responses occurred for you in the current episode, and you get a score, and you even get more points if ECT didn't work. And boy, talk about depressed. If you score a 5 on the MGH rating system, your odds of remission were 0. How do you maintain hope? Well, your MGH staging score is a 0. Now what? Acceptance and commitment therapy? Again, this is probabilistics. So yes, if ECT didn't work and if enough things didn't work, the odds are certainly low. I prefer this rating scale. I urge you to become familiar with the Maudsley staging system if you treat or refer or both patients with hard to treat depression. Why? A few reasons. So it doesn't give you an all or none. It's like staging the same way you might stage cancer. So how long has your episode been going on for? How severe are the symptoms? And all important, how many things didn't work for you? If I'm a level 4 or level 5 patient, and honest and truly 10 medicines didn't work, I've seen such people, please don't say to me, well, you haven't tried paroxetine, because that is a waste of time. There's no data with that drug for people that failed 10 things. In fact, very few things have been shown to work when 10 things have failed. So you tally these things up and you get a score. If you refer a patient with a Maudsley stage 3 TRD, the range of options is way different than if you're referring somebody with a Maudsley stage 14. And whether you do the actual numbers or not, you sort of have to have the appreciation for all these moderators that will inform what are viable treatment options. So speaking of the number of failed treatments in the current episode, when I comb the literature, ouch, not many things. The TRD literature mostly confines itself to 2 things that haven't worked before. Vagus nerve stimulation is when 4 things haven't worked before. My friend Scott Aronson published this paper in the American Journal some years ago. On average, patients had failed 8 things before. So that gives them a Maudsley level 4 of 4, which is still not in itself up here, but you get the idea. But wow, 8 things haven't worked. And here he gets a 67% response at 5 years. But how long till it kicks in? A year. Vagus nerve is not a fast acting treatment. So Mr. or Mrs. Maudsley, stage 11, level 4, more than 10 treatments. I'm going to give you this treatment. How long till it kicks in? We need to give patients some perspective. You have a hard to treat form of this illness. It's not untreatable. But let's be clear. There are no fast acting remedies in this instance. That's not to say there aren't options to try, but I would be lying to you if I said this is going to fix things overnight, or if I give you something random. You saw all those slides before with the overlapping confidence intervals. My internist said, let's try escitalopram. You're throwing spaghetti at the wall and seeing what sticks if you don't pay attention to what's been shown to work. Well, I'm not ready to go to vagus nerve. All right, here's a few other things. Pramipexole. Jeff and I, before we began, we're talking about our mutual colleague who passed away not too long ago, Jan Fawcett, who was one of my early mentors. He's was in Chicago for many years. And finished his career in Santa Fe. Anyway, he published a really interesting, nice study with the drug pramipexole. If you know it, it's an off-label use. I said I'd tell you what's off-label. It's a Parkinson's disease drug and a restless legs drug. But Jan's study looked at people where 5 things hadn't worked. He found a 29% response rate in a large open trial. 29%, well, if 0% got better after 5 things, 1 out of 3 is pretty good. So there's a literature on this drug, and it is incumbent to be familiar with it if you see a Maudsley stage 11 patient who's level 4 is multiple drugs non-responsive. Tranylcypromine also is in this camp of things where many things haven't worked. Sadly, it didn't work very well in STAR-D with a low response rate, but they really underdosed tranylcypromine in STAR-D, and most of the people didn't know how to use an MAOI. So when you use it, you have to use it properly, and there's a whole literature on that. Fancy combos like mirtazapine and enlafaxine, but again, fancy combos don't necessarily have huge response rates. Deep brain stimulation, 7 or more things didn't work. 20% response, but that is off-label and highly invasive. And you'd think there'd be lots of other studies in very hard to treat depression, but there aren't. So let's spend the rest of our time talking some about, well, what are some of these viable options? So there's 2 drugs that are FDA approved for treatment-resistant depression. That means 2 things and no more than 2 things failed. One is olanzapine plus fluoxetine. We talked about these effect sizes before, 0.8 is large, 0.2 is piddly. How do you like 3.37? That is a really large effect size. Oh, but wait, olanzapine can cause weight gain. Yes, that is true. So now you've got to sort of present things from a pro-con risk-benefit analysis to the patient. You're a Maudsley stage 10 plus. Small range of options. This is an option. Tell you this, when it works, you'll know within, 20% response at 2 weeks, and 4 to 6 weeks would probably be a reasonably minimum adequate trial. If you're in that lucky son of a gun group where 3.37 effect size happens, you'll know sooner if it's going to work for you than if it's not going to work for you. And if you happen to have weight gain, there's all kinds of ways to manage that. So we're not without reason to confer some sense of hope and optimism. Ketamine, well, you all know about ketamine. This is just a quickie side-by-side of the IV versus S-ketamine. Was it 2 or 3 weeks ago? J&J went to the FDA and got the blessing. You can now use it as monotherapy. When they designed their original studies, it was just as an augmentation to a new antidepressant start, and now they've blessed it as monotherapy. But it's a little bit hard to compare side by side because the original studies were as augmentation approaches with S-ketamine versus monotherapy with IV ketamine. But look, large effect size. I mean, that's a large effect size with IV ketamine. Small number to treat. You only have to treat 7 people before you're going to see somebody better at 4 hours. 3 people before someone's better within 1 to 7 days. Those are really good numbers. S-ketamine is a little bit lower because it's compared to just an antidepressant new start. At least that's the old data. So these 2 molecules stand apart from everything else when it comes to hard to treat forms of illness. Here we have, whoops, I'm sorry, I'm losing my screen here. So this is a pooled analysis Sorry, folks. Um, this is switching to esketamine plus a new antidepressant. This is the effect size I showed you just before. Some unresolved questions. Those of you who are ketamine aficionados will follow this. What's the optimal dosing of IV ketamine? Last year, the FDA said do not give more than 0.5 mg per kilo. Even though plenty of people do more than that, the FDA got real persnickety about that, and there's been a lot of exchange back and forth about do higher doses confer a better effect or not. How frequent should treatments be? Because the S-ketamine trials involved 8 insufflations. To be tit for tat, IV ketamine nowadays tends to be 6 to 8 infusions in order to judge response. But the inside word seems to be if you haven't seen signs of improvement after 3 or 4 treatments, the odds are pretty low that it's going to turn things around. And after 8, if non-response, my colleagues in the ketamine world call that futility and onto something else. Jury's kind of out about other forms like oral ketamine, these atrocious. It's got low bioavailability. What about the IM forms, which aren't really that established? So the FDA steps in and says this is all off-label if you're not giving intranasal S-ketamine. And it is still kind of the Wild West in terms of all these things, and clinical practice tends to outpace the evidence base. Here's a quick review on oral ketamine, which even though its oral bioavailability is pretty low, here they're looking at 0.5 to 1.25 mg per kilo. They actually did find a signal for improvement. Still debated. This is one of those areas that you would say to people, off label, jury's still kind of out, and FDA isn't going to go near this because it's so off label. Here's a famous study from a year or two ago comparing IV ketamine to ECT in TRD, looking at non-inferiority. That means not is one better than the other, but are both equally lousy. That is, neither is worse than the other. That was their study design, and they showed, yes, indeed, either ketamine or IV ketamine nor ECT is worse than the other. And in fact, numerically, ketamine actually edged out ECT, which is a bit contrary to some earlier studies which found ECT kind of rules the roost. So many would say, at least based since this study came out, ECT and IV ketamine are kind of at the top of the pyramid when it comes to what do I do for hard to treat forms of depression. My Maudsley stage 13s, my MGH staging where it's 5 or 6 on that scale, where many things haven't worked. So when should I be giving patients ECT or ketamine? Well, not everybody. I mean, this again, probabilistically, but if you've failed several things, this has to move up the algorithm. This is not the umpteenth thing, either of these, that you're going to want to try. And it's informed by severity, standout symptoms. IV ketamine does exert an anti-suicide effect within 7 days. That's been shown. ECT has value in psychotic depression, which ketamine may not. ECT has value in depression and pregnancy. I mean, this is where you have to sort of incorporate the totality of your knowledge base. How about adding on atypical antipsychotics? That's what we do, isn't it? Yeah. These now several agents are on label as augmentations to an incomplete response to a monoaminergic antidepressant, cariprazine, olanzapine uniquely added to fluoxetine, aripiprazole, quetiapine, brexpiprazole. They all are about comparable in their number to treat. Arguably, olanzapine fluoxetine has the lowest NNT and aripiprazole as well. And a number to treat that's under 10 is considered clinically meaningful. So yeah, 12 and 14 and 11 are okay, but they're not knock your socks off. So this is better than placebo, but it's not, again, kind of the silver bullet. Pramipexole, I mentioned this drug to you before, the Jan Fawcett drug. Patent died before any drug company was going to invest the efforts and resources to really develop it. So there's a number of mostly small proof of concept randomized trials. I was part of one of these years ago. And it can work when other things don't. And off-label use, D3 agonist, you have a lot of D3 dopamine receptors in your reward pathway. So this may have particular value for anhedonia, for apathy, amotivational states. Wouldn't use it in an agitated depressed patient, wouldn't use it in a psychotically depressed patient, but it might have value in a very lethargic, anergic presentation of depression. Again, off label. Here's Jan's data. I showed you this before. So 5 prior things that hadn't worked and pretty impressive response rates, both unipolar and bipolar patients. What other kinds of augmentation things might one consider? Bupropion is a popular augmentation until this study came along a couple of years ago and said the effect size of adding bupropion onto an SSRI or an SNRI is teeny. It's 0.10. Really? Yeah, it's not that much better than a placebo. What's better? Mirtazapine had an effect size of 0.37. Oh, but that makes you tired, so you give it for sleep, and it may make you gain weight, so you use it for people that have no appetite. But an effect size of 0.37 is actually pretty respectable. It's an on-label use, mirtazapine, but it's often neglected as an augmentation strategy. How about lithium as an augmentation? NNT of 5, impressive. Odds ratio of response, threefold. Wow, why don't we do this more? Well, a few reasons. One, these are ancient studies. These are all added on to tricyclics or fluoxetine or paroxetine. I don't even think sertraline was around yet, much less the SNRI. So it's an old literature, and we don't know how well it works with modern antidepressants. It's got its side effect profile. Its antidepressant properties are not as robust as its anti-manic properties. So I offer this up as a consideration that's underused and just an acknowledgement that there's really no modern data with lithium. Stimulants or stimulant-like drugs actually have their place. Off-label use armodafinil, on-label for sleep apnea or shift work sleep disorder or narcolepsy, as an add-on to an antidepressant actually gives you a fairly decent effect size. 0.35 is pretty good. Same in bipolar depression. The odds of getting a remission 1.6 times higher. Might think of this option when there's lethargy, hypersomnia. It's not going to have an effect on appetite or weight. It's pretty neutral there. No pressor effect. It's got its role in very anergic, apathetic kinds of depressions. By itself, not known to do a whole lot, but well, as an augmentation in anergic depression, something to consider. Thyroid hormone, T3, tends to work better than T4. Not a bad number to treat. NNT of 4.3 is actually pretty good with a decent effect size. Why do we use it more? I don't know. We probably should, particularly if somebody's baseline TSH is in the higher end of normal. So this guy, Russell Jaffe, who passed away some years ago, was a big guru in thyroid research, said if your TSH is over 2.5, you're a candidate for T3 augmentation. Start at 25 micrograms. We check the TSH 4 to 6 weeks later. And there aren't large-scale modern randomized trials. I think that's one of the factors. And there's certainly no pharmaceutical muscle behind thyroid hormones, so it's sometimes not thought of. But with those caveats, it's something to consider. Here's that study I alluded to at the very beginning, that even ECT, and nothing's ever been shown to work definitively when EC does not. It doesn't work for everybody. And if you happen to have comorbid borderline personality disorder for whatever reasons, even ECT it's not going to work. But just in terms of anticipating outcomes and expectations, response rates are much harder. Hey, is that because of an epi factor like comorbid substance use maybe, or trauma history? We can speculate away, but the bottom line is it's harder to treat. How about TMS? Well, why am I making a face? Response rate's about 30%. Very low sham control response rates. So the NNTs end up being pretty respectable, but there's about a 1 in 3 chance of success. If you're going to do TMS, you might want to go to theta burst TMS. This is that very intensive 10 sessions per day for 5 days. It's a week out of your life. It's an off-label use. This protocol is not FDA approved, but there's some favorable randomized trials. The first that came out of Stanford 4 years ago. Holy smokes, 90% response rate. This included some ECT non-responders. Less traumatic data for bipolar than unipolar depression. Very active area of research. So something to consider when other things are not working. I told you about vagus nerve stimulation before. It can work. Two-thirds of patients are better and sustain response at 5 years, but this is not a fast treatment. It may take a year for this to kick in. So what do you do if ECT is not working? I don't have a controlled trial literature to share with you here. Clinical trials, maybe psychedelics, IV ketamine. Well, you saw the amide data I showed you from England Journal, where it was non-inferior and numerically superior to ECT. Maybe intermittent theta burst, TMS, MAOIs. There is a literature, case reports mostly, but these are patients that are, I think, among the most difficult to treat. If someone comes my way and ECT didn't work, I tell them up front, I may have nothing to offer you, but I can certainly tell you what options exist. Speaking of psychedelics, well, there's a handful of studies out now. This was the famous New England Journal study with the COMP 300 molecule, where it actually showed separation at week 3, kind of petered out by the end of the study at week 12. So it's not quite clear. Is this a one and done? Is there repeat dosing? There was some stray reports of suicidal ideation in the psilocybin takers. People who say, how about microdosing? Yeah, microdosing was the placebo arm. That was a milligram dose. And even 10 wasn't very impressive. So I don't think this is a microdosable thing if you're going after the antidepressant effect. Here's the meta-analysis to date as of last year. So you're 1.6 times more likely to get better with psilocybin than placebo, but we don't know if the effect endures. Do you need multiple doses? Is this an augmentation of psychotherapy or use it by itself kind of thing? Who's a candidate and who's not? Probably don't want to give this to psychotically depressed patients. What's the effect on suicidality? And how high a Maudsley score can you give a patient like that to are all unanswered questions. In bipolar depression, here's the 5 and only 5 FDA approved treatments, all with decent NNTs. Before you talk about treatment resistant bipolar depression, make sure you've gone through the standard fare. Don't use lamotrigine in treatment resistant bipolar depression. Andy Nierenberg showed it really didn't work very well, so it's not on the TRD list. ECT has a database in bipolar depression. I'm going a little quick here to wrap up, but you can certainly get my slides. Email me if you don't have access through Silver Hill. Happy to share them. So this is not to forget as an option in hard to treat bipolar depression with decent response rates, 68% in bipolar depression with or without mixed features. A chip on every number. You could certainly put together the Frankenstein of psychopharmacology. Mix this with this, with this, with this, with this, with this. This is where art outpaces science. I guess you could do this. It's just we're really getting into the stratosphere or the whatever's beyond the stratosphere when it comes to that. Think about next steps ahead. If you're going to start with something with a long half-life and you're contemplating an MAOI, you might want to use something like esketamine or lithium as a bridge to get there, because if the fluoxetine part of OFC doesn't work, I can't give you an MAOI till 5 weeks later, so I have to have some plans in place. Pramipexole is also compatible with an MAOI, TMS. So this is where the chess pieces have to fit together in iterative psychopharmacology. Now and then we use the word futility. This is a paper of mine, which I guess I'm going to go to jail now. It's illegal to post this. I'm the editor of the journal. I can do whatever I want. So this paper, even though the title sort of implies we're out of ammo, kind of says there is a point at which you might have to adopt more of an almost palliative mindset, which is to say, look, many biological interventions have been tried. They were appropriate, they were adequate, et cetera, and they haven't worked. It doesn't mean we give up, but we do have to shift our thinking now to the chronic illness model. How are we going to help you manage this condition that's not going away anytime soon? Several fold, and this paper talks more about these details. In the here and now, this is where something like an ACT approach becomes very helpful. You might want to have targeted approaches, like we're not going to make your depression go away, but maybe we can help your insomnia, or maybe we can help your anxiety, or something a little more modest. How do we help you live with this? As new things come along, are you a candidate for them? So it's really sort of the critical balance of maintaining a sense of hope and not succumbing to hopelessness, but at the same time, not being sort of zealously unrealistic and saying, "Oh yeah, we can make this go away." These are the sort of the humility of medicine and knowing how to manage a chronic condition. So here's my final slide. Majority of mood disorder patients, unfortunately, will present with difficult to treat forms of illness. I've talked about ways of really not just saying, "Okay, this is hard to treat," but delineating these moderators and comorbidities and parameters and Maudsley scales, et cetera, that will help you maybe pinpoint where the person is in their trajectory of the illness, so that you can then formulate viable options to intervene that will either be disease modifying or disease managing. The difference being modifying is, can I get you better? Managing is, can I improve your quality of life? Are there things that I could do that might make incremental steps on this sometimes unfortunately long journey to try to get to recovery? So the easiest way to get there is to intervene early and appropriately and not wait until things have become Maudsley stage gazillion. All right. Well, with that, I think got about 15 minutes for some comments. So I'll turn things back to Jeff at this point.
Wow, that was like an encyclopedic talk. We will, I want to watch it multiple times. Dr. Goldberg was so informative. Thank you. Thank you for being with us. Thank you for all the information. We have lots of questions that come in. So why don't we get to them? Uh, the first was about a comment you made early on. It says, can you repeat the fact about how many neurons you lose in an alcohol binge? Um, so yeah,
25,000.
okay.
Yes.
Mhm.
Enough to make a mark.
Yeah,
So
yeah, yeah,
tell your
yeah.
patients, you need to be informed. So when you're doing motivational interviewing, so, you need to know what you're doing. I mean, the same as if you're going to smoke cigarettes, same as if you're not going to wear a seatbelt, be informed.
Great, great. There's a question out here about Suboxone. Can you say something about that in terms of that counteracting the efficacy of antidepressants is the question, and how to think about that.
Counteracting the efficacy.
Yeah, that's what the question is about. Yeah.
Hmm. So at one time there was interest in whether Suboxone might have some antidepressant properties, and there's this whole world. I'm going to give you a long-winded answer, but the short-winded answer is don't know. Long-winded answer: there's an ongoing great deal of interest in whether kappa opiate receptor antagonists might have some antidepressant properties. Um, Samidorphan, which is now paired with olanzapine to make the proprietary drug Lybalvi, and has been shown to reduce the amount of weight gain, was originally looked at as an antidepressant. It did not work. Aticaprant, a drug made by Neumora, another kappa receptor antagonist, just released their negative findings in their large randomized trial after initial positive proof of concept study. There are other molecules that are kappa opiate receptor antagonists that are of interest as potentially leveraging depression. Now you could add, and there's also some data with not a lot when things like naltrexone or mu antagonists are added. You can make the argument that a mu antagonist is an anti-euphoria drug, and so to regulate reward, I give you a mu antagonist, and will that sort of make alcohol look less attractive? So my reward circuitry doesn't go bananas when I see the associative cues, which is to say, can I mitigate the euphoric effects? I don't know any data that says if you give Suboxone, you'll make someone depressed. But I suspect some of the complexity has to do with what has been their opiate use history and duration and chronicity and any comorbidities, um, uh, and things like protracted abstinence syndromes for some people that might also be a factor in dysphoria. But I think there's still a very active area of interest in modulating the opiate system in a way to try to leverage it as an antidepressant. There's one company that's developing a mu antagonist as an antidepressant, which may seem counterintuitive. As I say, if you block mu, you might have an anti-euphoria effect, but we don't know. I don't know.
Great, great. Thank you. Dr. Bettina Bernstein out there is asking about, this is probably a whole long conversation too, about nutritional interventions and supplements and like folate and methylfolate, as well as yoga and
Um,
acupuncture, what we know about those in terms of depression.
So let's see. There's a mix here of complementary and alternative medicine, like yoga and acupuncture, with nutraceuticals, with food products like L-methylfolate. So let's see. L-methylfolate is certainly benign. There was interest at one point in, if you're into pharmacogenetics, if you happen to have the low activity variant of the MTHFR gene, in principle, you can't transport folic acid into your brain across the blood brain barriers efficiently because you need to methylate folic acid. And so, shouldn't that be a reason to give somebody L-methylfolate? And George Papakostas, that same iconoclast who said SNRIs are piddly after an SSRI, also showed, nah, actually, the low enzyme activity form of MTHFR doesn't predict L methylfolate response. So that's an example of a drug that goes on a list of things to try, but sure not in the TRD realm. The APA practice guidelines advocate exercise as a first line treatment for mild to moderate depression. It sure does no harm in TRD, but I've never seen a study looking at any CAM or exercise in TRD. So I think the takeaway here is sure, these are all things that can be beneficial. The lower your Maudsley score is, and heck, behavioral activation is a core tenet of CBT. You'd be remiss to say, yeah, lie in bed till 2 in the afternoon and ruminate. Sure, be sedentary. Why not? So some of this I think makes sort of behavioral sense. But in terms of, once you've not gotten better with two treatments, or your Maudsley score is going into the moderate to severe range, narrow options exist. And so you'll get the most bang for your buck with CAM and with behavioral approaches if your Maudsley score is low.
Great. Many comments here about what a great presentation this is, Joe. So thank you very much. A question here, does thyroid augmentation predispose to the emergence of psychotic symptoms and psychotic depression? And have there been any studies looking into this?
Not to my knowledge. Suprametabolic thyroid hormone for a while enjoyed some popularity in rapid cycling bipolar disorder. There haven't been gigantic studies, but in the data that's out there, I don't recall ever seeing a worsening. Now, I guess you could argue, well, what if you make somebody hyperthyroid? Do they get agitated and activated? So the suprametabolic gets your T4 into the upper quartile range. I don't think is translated into the autonomic hyperactivation that you'd see with somebody, say, in thyroid storm. I think it also either works or it doesn't. There's this one guy named Tam Kelly, just in case you come across this. He's out in, I think, Colorado. So he published a paper saying, look, if you're going to use thyroid, you really got to use it. So you got to give people like 300 micrograms of levothyroxine. That's like a gigantic dose. And you got to get their T4 up to here. And in his hands, that works. He published a somewhat controversial paper in Journal of Affective Disorders some years ago. And every now and then a resident comes to me and says, can I do this? I say, well, it works for him, but it hasn't really been widely grasped. And then the internists always get freaked out about things like arrhythmias or osteoporosis in older patients. So I don't think I'd be as concerned about psychosis as much as cardiovascular and bone health. And plus, just if it doesn't work, it doesn't work.
Great. David Mathis is asking a question about the prevalence rates of trauma and addiction in treatment-resistant mood disorders, and what do we know about that?
It's high and it's bad.
Hmm.
And
as you said,
this is and this is Charlie Nemiroff's work at this point. Charlie's sort of converted his whole, he went from stress response and glucocorticoids. Now he's just looking at trauma, and it's epigenetic adverse effects on the organism. And when last I spoke with him and said, so do you have any preferred treatment for TRD when there's a trauma history? If you ever met Charlie, he's very kind of poker. He's like, no. And then you're waiting for him to say, but, and there's no but. So I think it's really, really hard. That doesn't mean it's untreatable, but, buckle your seatbelt. And I guess it means trauma work's got to have some role in this. If there's comorbid PTSD, there's some new data that just came before the FDA using adjunctive brexpiprazole with sertraline in PTSD. They're going for the indication. Laurie Davis published that paper in JAMA Psychiatry in December. Can't tell you that's the go-to, but maybe there's some value with trauma. I realize that trauma history is certainly not synonymous with PTSD, but I think this is just an enormously difficult area. I was dreading this question because I don't have a good answer for it.
Yeah. Great, thank you. Christine Miller is asking a big question, important question. What treatment would you lean toward for patients with significant medical issues in TRD, for example, autoimmune diseases or chronic pain or others?
Well, let's see. If I have an effective treatment for depression, maybe that will reduce inflammation. Big maybe. I don't think anybody is going to go out tomorrow and say, let's use infliximab as an antidepressant or celecoxib, or go after, the anti-inflammatories as the depression treatment. There's this interesting interplay, depression and inflammation, and nobody, I think, knows if one causes the other or they just happen to co-occur. So I don't think, there's obviously a whole literature on treatment of depression, the medically ill, and there's the first do no harm stance. So let's see, what would be the kinds of things that would be relative contraindications? If somebody's metabolically dysregulated, I'm not as eager to give them an atypical antipsychotic with high liability on that front, unless I have to. MAOIs are a risky proposition if someone's got ischemia. I've had more than a few patients who did uniquely well with MAOIs but had heart attacks, not because of the MAOI, but in the course of life. And at that point, it would be really heroic to continue an MAOI. You might. It's just MAOIs can cause ischemia even without tyramine. So it's a risk. On the other hand, if nothing else works, I think pramipexole, that little Jan Fawcett drug I was mentioning before, off-label, is very well tolerated and underappreciated because it is off-label. So nausea is the main side effect with it, and it's pretty surmountable. Ketamine is actually pretty benign, right? You've got the transient dissociation, and unless you're using way too much of it and you get bladder complications from overuse, it's a pretty well tolerated treatment. And there are no absolute contraindications to ECT. Is Henri on the call? He can chime in.
Yes.
So feel free to disagree, but to my knowledge, there are no absolute contraindications to ECT and hard to treat depression.
Great. And what about chronic pain? How do you think about that?
I try not to.
Yeah.
Yeah, very, very difficult. Don't you all have a program in that? I think it's a good example of a dual diagnosis where you have to find a way to treat both. And certainly, if neuroadrenergic antidepressants can make inroads, people like to talk about the spinothalamic tract running on noradrenergic transmission. And so if you're giving somebody either a secondary amine tricyclic or an SNRI, maybe you can get a twofer on that front. If there's neuropathic pain, you might have a little more leverage than if there's musculoskeletal or bony pain. Those are really tough. Patients that have had orthopedic injuries or vertebral fractures. I don't know how to treat those people. I send them to you folks. But for neuropathies, you cross your fingers. You can maybe get some mileage with something noradrenergic or a gabapentinoid or the combination. But I think or novel strategies and complementary alternative approaches, and having a good pain specialist in the picture. I think it's a good example of a dual diagnosis where there is no easy answer.
Question here about Auvelity and zuranolone.
Mm-hmm. Specific question or just free association?
Just says, what about? Yes.
So let's see. Auvelity is the unique combo of dextromethorphan with bupropion. The bupropion is there not for its antidepressant sake. It's there to block 2D6 and raise up dextromethorphan high enough to get an antidepressant effect out of it, and blocking its conversion to dextrorphan, which binds to the PCP receptor and does other undesirable things. It works. Axsome did a randomized trial in treatment-resistant depression called the STRIDE-1 study, where it failed to beat placebo. They never published that study. And so I think it stands as another option to consider, and you're welcome to try it in TRD. but there isn't a database to support its use. And I don't think they've identified earmarkings of here's a good candidate, other than it's well tolerated. There's no weight gain, there's no sexual side effects. Zuranolone bit the dust. I mean, aside from postpartum depression and a nice theory about allopregnanolone levels going down in pregnancy, when the company looked at it in just major depressive disorder, the FDA killed it and just said, your data stink. They kept moving their outcome measure. First, they looked at uh, day 31, then they changed to day 14, then made day 7, and they just kept changing their study design. So I think that study, it's um, zuranolone is a positive allosteric modulator of GABA A receptors. It's a neurosteroid. It's a novel approach. I think their study designs were overly ambitious and not well done, and that's why the FDA dinged it. I'm not sure if they plan to do more things with it. You're welcome to try it if your patient has $16,000 to spare, because insurance ain't going to pay for it off label. And postpartum, the IV infusion over 60 hours, it's about $1,000 an hour. I think it's 60,000 bucks. And my repro psych colleagues say I'd rather use sertraline for postpartum depression.
So we're at the hour. Let me end with this comment from Jerry Pavlon Blum, who says, wow, 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 wow. Brilliant, playful, exact, and super ready for prime time. Thank you so much, Doc. Thrilled to absorb and consider even the bit I can hold being an education leader and not a doc. So with that, Dr. Goldberg, thank you so much for being with us and sharing really encyclopedic knowledge. We will post this, and I think people will want to watch it kind of again and again. So thank you. And again, for those desiring to receive CME or CEU, please fill out the form that will pop up at the end of this presentation. And we've been with each other for a bit now and together, and now we'll be disconnected. So until next time, thank you everybody for joining again. Thanks for Dr. Goldberg for a tremendous presentation and for being with us
Thank you
today.
all.